from the American Academy of Pediatrics.
There is so much we have learned in recent years about peanut allergies, from how to potentially prevent them to how to treat them, and in some cases, even cure them. Today, we are talking all about it.
What we've learned is that every month that you wait to introduce peanut to a kid with moderate to severe eczema increases the odds of the kid developing a peanut allergy by 30%. And so that's where families working with their primary care teams to try to target that 4 to 6 months of life is important.
Welcome to Healthy Children, the podcast for parents from the American Academy of Pediatrics. I'm Dr. Edith Bracho-Sanchez. I am a pediatrician and a mama figuring it out. This is a judgment-free space where all questions are good questions, and the answers will hopefully be even better. Let's get started. Today, we're talking peanut allergies, and to do so, we have with us Dr. Michael Pistiner, who is a pediatric allergist at Mass General for Children and the Director of Food Allergy Advocacy, Education, and Prevention. Welcome, Mike.
Thank you for having me.
Mike, and I just want to say for our audience that I'm calling you Mike because your patients call you Dr. Mike.
Yes, absolutely. When they can speak. Many of my patients are infants and toddlers, and their parents can call me what they want. And once the kids can speak, they can also call me what they want. But Dr. Mike is usually a little easier than the mouthful of Pistiner.
I love it. We're so happy to have you, Dr. Mike. So to start at the beginning, tell us a little bit about what happens in the body of a little person who develops an allergy to peanuts. In other words, how does this work at a basic level?
All right, so I guess the first thing I just want to mention is everybody picks on peanut. Peanut is the allergy that lots of people have been doing research on. Lots of advocacy efforts have started and grown from there. But any food can potentially cause an allergy similar to peanut. And so when I'm talking a little bit about what's happening with a peanut allergy, you can take this and apply it to milk, eggs, tree nuts, sesame, other potential allergens. So if someone is allergic to peanut and we're thinking about the kind of reaction that can cause coughing, wheezing, barfing, sneezing, usually something called IgE is involved. IgE is immunoglobulin E. This is a protein that our immune system makes. So our immune system is what we use to fight germs like bacteria and viruses, but sometimes a kid's immune system can get a bit fired up and it can act in a way against something that is usually not a problem for other people, like a food, and in this case, like peanut. And so if somebody has a peanut allergy, then their body sees peanut as a foreign invader, and perhaps you could think about it as a germ. And immunoglobulin E, IgE, may be made by their body. Now, IgE can be circulating around somebody's body, but then we also have allergy cells, and some of the ones that I like to talk about are called mast cells and basophils. And these allergy cells can have IgE, immunoglobulin E, on them, preloaded, ready to go, if somebody were to then eat their allergen, and in this case, we're talking about peanut. So if a kid eats peanut after they already have an established peanut allergy, and their allergy cells are preloaded, their mast cells and their basophils are preloaded with IgE, when the protein then touches the IgE, then they can have signs and symptoms of an allergic reaction.
Mike, I am so glad I asked you that question to start this conversation because that was such an amazing and thorough explanation. And I think a lot of parents sometimes want to know, like, what is going on in the body of my little person? So I really appreciate that. Now, tell us a little bit, how common is this? Like, how common are peanut allergies? How common are other food allergies?
Food allergies has been a growing national and also international issue. And so over the last 20 years, there's almost been a tripling in peanut allergy. Now, you say somewhere in the United States, somewhere between 1.5 and 2% of kids has a peanut allergy. Between like 8 and 10% of kids may at some point have a food allergy. Now, when we'll be talking food allergy for the rest of this podcast, I'm talking about the IgE-mediated kind that can cause coughing, wheezing, barfing, sneezing, And we're talking about peanut allergy, but those common allergens are seen with peanuts, eggs, cow milk protein, tree nuts like cashews, walnuts, pistachios, sesame, fish, shellfish, and soy and wheat.
Yeah, I love it. So I want to ask you, Mike, to hone in a little bit on something that you mentioned, and it's this rise in food allergies like the ones we're talking about over the past few decades. And I want to ask you specifically because I think we as medical providers, clinicians had some to do with the rise in food allergies. Not that it's entirely our fault, but we had some to do with that. Talk to us about it.
All right, so first I'm going to talk about some guidelines, and then I'm going to talk about my own family. So back in 2000, based on best guess and the data that was available back then, the American Academy of Pediatrics released recommendations to delay the introduction of highly allergenic foods. So in those recommendations, in this clinical report, it was recommended to wait to add dairy until age 1, eggs until age 2, peanuts, tree nuts, fish, and shellfish until after age 3. And once those recommendations were released, there continued to be a rise in peanut allergy and food allergy, and it may have even sped up. So now in the personal perspective, back then I was a new dad about to introduce foods, and we delayed the introduction following those recommendations in him. And wound up not giving him walnuts until he was about 3.5, when I was already a pediatric allergy fellow. And then in addition to being a pediatric allergist who really enjoyed teaching about food allergy, I became a dad. And that's when I really got deep into advocacy and education. But my wife and I really enjoyed eating cashews and walnuts and pecans, and we're eating those around him, but not feeding those to our son. And we delayed the introduction until around after age 3. And so on that first introduction, he wound up having what was anaphylaxis. And so I wish I knew back then what we know now, but now it's amazing that the research and the science is showing that the early introduction of these, in fact, is protective, and that there's no reason to delay the introduction of peanuts or highly allergenic foods after 4 to 6 months of life of exclusive breastfeeding. In fact, now we have awesome data that says, yes, please go for it with peanut, because you can significantly decrease the chance that your baby develops a peanut allergy by early introduction. And in a kid with no risk factors, we're talking about around 6 months of life. But in a kid who has risk factors that include severe eczema or already established food allergy, shooting for 4 to 6 months of life is what we're wanting to do now. And it makes a big difference.
Yeah. So let's backtrack for a second, Mike. So let's say I'm a mom of a little person and they're between 4 and 6 months. They're, pretty good in their motor development. They're very interested in food. They're holding up their head. They're almost ready to sit. And I'm like, I want to feed this baby. Tell me the logistics. How do I introduce all these things? What do I do?
All right. So you're going to be thinking about first getting the kiddo ready and prepared with some sort of perhaps baby cereal, an infant cereal, where they're learning some of their skills, where they're learning how to figure out what to do with their tongue, how to swallow, how to handle this new complementary food. One thing I just want to lay out here is that when we're thinking about the introduction of foods at this point, we are not talking about weaning. This is talking about the introduction of solids, complementary foods for developmental readiness, for skills, for fun, for nutrition. But if a family is choosing to breastfeed, continuing on with that, continuing with breastfeeding or infant formula as the main source of calories and nutrition, while adding these allergens at the same time as complementary foods. So a kiddo first gets comfortable with like an infant cereal, then maybe a pureed fruit, a pureed veg. They're killing it. They're doing great. Now you have something you could mix other foods into. So now when we're talking about peanut, the studies are suggesting that you want to get a kid to have reasonable quantities and do it at a reasonable frequency. So the study that everybody has been hanging their hat on, which is a great, well put together study that scientists agree was done in an awesome way and that we could trust the data. This study was called LEAP, Learning Early About Peanut. They took about 2 grams of peanut protein, and one of the ways they gave that to babies was smoothed out peanut butter mixed in something else. Something mixed in like that infant cereal I talked about, in that pureed fruit like peaches or apples,
Right.
or in a pureed veg if you want to be kind of gross. So that would be the way to do it. One of the things is with the early introduction of any of these complementary foods, we want to be thinking about not adding a choke risk. So if anybody's adding peanut butter or other nut butters or sesame tahini, thinning it out with one of the already tolerated foods is going to be something important. You're not going to just introduce peanut butter to a baby who's never touched a solid before. You're going to want them to have this skill. You have your confidence to then get this smoothed out version into their diet. Now, obviously, right when some of these allergens are added, a little Magoo, a kid between 4 and 6 months, can't possibly have the goal quantity right in the first or second or even third time, but building up for a goal of about the 2 grams, which is about 2 teaspoons of the peanut butter or 2 teaspoons of a smoothed out nut butter, is going to ultimately be the goal, and keeping the peanuts in for about 3 times a week, because that's what the study did. And they did it pretty frequently in a pretty good amount, but it worked really well. They kind of went into the study that then the guidelines are based on with a go big or go home mentality, and it really worked. So that's where the science is. But then other allergens, when you're adding it and you're doing kind of what we learned with peanuts. So something like if a family really enjoys having cashews, smoothed out cashew butter, shooting for about 2 teaspoons twice a week, or twice a week for any of those tree nuts or sesame is probably a pretty good goal.
So tell us a little bit about how it works in the body. What happens when you introduce peanuts, eggs, soy, shellfish to a baby at a young age? Does the body learn to tolerate it? Like, how does it work?
One of the things to talk about a little bit is that when it's thought that that early introduction, before a kid develops an allergy, if they meet the allergen through their gut, then likely that is the tolerizing route. So I'll use the word tolerance for a kid who can eat a food without an allergic reaction. Now, on the other end of that is the word sensitization. Allergists and clinicians are using now the word sensitization to mean that a kid makes IgE, as I mentioned before, immunoglobulin E, to a particular allergen. And so if a child has a blood test or a skin test that detects IgE, then we can say that they're sensitized. The more IgE you make, the more likely that sensitization is clinically relevant. Just because a kid makes IgE on a blood test or a skin test, it doesn't mean it's going to cause an allergic reaction when they eat it.
Right.
But if the child eats a food when they are in that development of sensitization and they're not yet clinically allergic, we can actually keep them from being sensitized and clinically allergic, and we can help them stay on the path of tolerance. So there's this theory called the dual exposure hypothesis, that the skin is the sensitizing route and the gut is the tolerizing route. And if you are constantly coming in contact with allergen through your skin, especially if your skin has barrier dysfunction or inflammation, and that can happen in eczema. And so if a kid has eczema can cause a breakdown in the skin, barrier dysfunction, and kids can get red and itchy and have angry rashes. And if they're coming in contact with allergen on especially their eczema, where they have this barrier dysfunction and inflammation, they can then get sensitized. So the thought is that we have immune cells under our skin. The these antigen-presenting dendritic cells. And if you're coming in contact with food through your angry eczema skin, then that might be a route of sensitization. And so that's kind of where, when there is a baby who has severe eczema, especially, thinking about even earlier introduction, around 4 to 6 months of life, makes a lot of sense. And some of the studies are showing that that might be the sweet spot. And that may make it so with that early introduction, now you're getting the opportunity for the gut to see the food first before the kid has developed a clinically relevant food allergy. Now the baby eats the food in routine amounts and decent frequency, and the immune system of the gut, the T regulatory cells, can chill things out. So now you got this balance between the skin and the gut, the dual exposure hypothesis. And so now, to answer your question after my long-winded response,
which I've really appreciated,
which is that if there's a delay in the introduction and a child comes in contact with allergen on their skin routinely, and one example I like to make is, let's say grandma loves cashews and grandma eats them like this, like normal people.
For everyone wondering what you just heard, Mike is literally showing us how grandma will eat cashews from their hands and then rub their hands, wipe them on their clothing. We all do this. I'm guilty of this.
I'm eating them, and now I'm dusting off my hands and I'm wiping them on my shirt. And now the baby wakes up from the nap, and now I cuddle with the baby on my shirt. And now I apply the moisturizing lotion on my baby's skin. I put the eczema cream on my baby's angry eczema skin. I do a diaper change. I mash in Desitin in their angry butt. I put on the diaper and then I wash my hands. That might be a route of sensitization. And not picking on grandmas, but this is the way so many of us eat peanuts and tree nuts. And so this is just the norm. And thinking about these very normal patterns might be something that we can do until we can feed our babies. And if that happens again and again and again and again, we're not talking about a once and done here. We're talking about constant exposure to allergen that the baby does not have an opportunity to eat. That could be a setup. So I like to talk to the families that I take care of in my clinic. Well, first off, by the time a kid gets on the schedule to see me, a pediatric allergist, it may already be too late. That ship has sailed. They're coming to see me because now they had an allergic reaction. They want to know what to do, or they want to see me early. But unfortunately, my next available, unless I pick kids off my schedule, is literally August or September. So that kid is driving by the time they see me. So we have lost the opportunity to do the early intro, right? So this is going to be where you're not going to want to wait. You're going to want to get the show on the road. But keeping those constant exposures in mind, good hand hygiene, good hand washing before applying creams or lotions, especially in a kid with eczema, and then thinking about what are the family's favorite foods? What is in the environment? What's in the dog chow? 40% of dog food can have egg in it. Some dogs enjoy peanut treats. Thinking about the dog running around the house, getting all their dog food everywhere, licking the baby. These are things to keep in mind. And these are reasons to want to get that early intro going. And then targeting around 6 months in a kid without eczema. But if the family, like you said, if they want to do it, if they understand how to do it and they feel great, then 4 to 6 months is an awesome target. But if the kid has severe eczema, that's really going to be a good target. And so having conversations early on, right when eczema is first detected, and with the goal of, let's get food on this baby. How are we going to do it? Let's make it fun.
Yeah. No, and I love that you explained all of that, because so often I think there's still this notion that babies with severe eczema should wait to see you. I see this all the time. Families want to see you before they introduce allergens in kids who have severe eczema. And it's no, we want to take care of the eczema. We definitely want to heal and protect that skin barrier. And we want to introduce through the gut as early as possible, as you mentioned, for the reasons that you mentioned. So I really appreciate your explanation.
here's one kicker that I just kind of want to throw in there is that right now, so that study that I mentioned, the LEAP study, that was released in 2015. And then based on that came the guidelines, or they're called the Addendum Guidelines for the Prevention of Peanut Allergy in the United States. And in them, they recommend having a screening step. So they recommend talking to your pediatrician who could consider doing testing prior to the introduction of peanut for a kid with severe eczema. But since then, we've had a hard time implementing throughout the United States. So now people are talking about maybe not doing the screening step if that slows things down. What we've learned is that every month that you wait to introduce peanut to a kid with moderate to severe eczema increases the odds of the kid developing a peanut allergy by 30%. And so that's where families working with their primary care teams to try to target that 4 to 6 months of life is important. And in some cases, an allergist might be helpful to get the show on the road. But in other cases where access is a problem, we might be a barrier.
Yeah, absolutely. Now, Mike, 2 quick questions before we wrap up our show. What about kids who have a family history of peanut allergy? Should they wait to introduce, or should they see you first, I should ask?
All right. What we're learning is no, you don't need to see an allergist or do any testing different if you have a family history of a peanut allergy, mom, dad, brother, sister. And in fact, if you needed to wait, then that could actually increase the chance that the kid would then have a reaction because they don't get it in their diet on time. So shooting for around that 4 to 6 months of life, around 6 months of life in a kid who doesn't have eczema or other significant risk factors without the need to see an allergist is the way to go.
So another thing that's not a reason to delay early introduction of peanuts. Now, one of the things that excites me, Mike, as a primary care pediatrician, I'm sure for you, it's close to your heart, is the number of things that can be done now for kids with peanut allergy specifically. Talk to us about the latest science.
Yeah, so then with all we were talking about prevention, sometimes it doesn't work. And then sometimes it may be too late. And so we are going to, and we continue to see kids who are developing peanut allergies. And this is an exciting time to be peanut allergic. So it sounds weird to say, but it's a good time to have a peanut allergy. And the kids these days who are developing peanut allergies are likely going to be having a very different course. And treatments are popping up left and right. And we have some FDA approved treatments that actually have now been approved for age 1. So peanut oral immunotherapy has an FDA treatment that now recently has been approved from 1-year-olds and up. Prior to recently, it was 4-year-olds to 17, and now it's 1 to 17. There's a medication now also approved for 1-year-olds and up called omalizumab, which is a monoclonal antibody. In the pipeline, there is a patch that's being developed for peanut. Also in the pipeline is toothpaste. Also fecal transplant. There's amazing things that people are working on. And so I think that the kids these days who are developing peanut allergy and other food allergies are going to have many options as the years roll out.
Yeah, toothpaste. I had not heard about that. So exciting. Mike, we like to end our show with what we call a parenting prescription. So when it comes to peanut allergies, what is one thing you want every parent out there to know?
That introducing food is fun and awesome. And so if I'm talking to the parents of kids who are still infants introducing foods, then go for it. Have a great relationship with people supporting you for infant nutrition. So not only your primary care, the pediatric team, family medicine team, but then also if you're receiving WIC, if you have RDs or nutritionists in your life, talk to them about early introduction. And this is a normal, awesome thing. And now, if your baby happens to have severe eczema or already has a food allergy, then start talking to your primary care team as early as you figured it out. And if you do have any worry or concern, talk early about this stuff. So when I say early, I'm talking like 1 to 2 months, 3 months, so you can come up with a plan. So if you need me, then your kid won't be too old.
Yeah, I love it. This was such a fun conversation. Thank you so much, Dr. Michael Pistiner, for joining us today.
Thanks for having me. This was super fun.
And thank you at home for joining us as well. If you like the Healthy Children podcast, please subscribe on your favorite podcast app and help us spread the word. Follow Healthy Children on YouTube, Instagram, Facebook, and Threads at Healthy Children AAP, and be sure to visit healthychildren.org, the parenting website of the American Academy of Pediatrics. Healthy Children is a production of the American Academy of Pediatrics. Our creative team includes
Laura Alessio,
Catherine Beard,
Garrett Brown,
Zach Christman,
Ann Johnsos, Kathy Jewell,
Claire Keating,
Doug Nagel,
Jackie Ortega, Susan Stevens Martin,
Mary Claire Walsh,
Hannah Weston.
And our theme music was composed by Doug Nagel. We'll be back next week. I'm Dr. Edith Bracho-Sanchez. Thanks for listening.